mentioned Parkinson's plus syndrome and Parkinson's disease.
Yeah.
What is the difference between the two, and how do you know which one you have?
Yeah. So there are different types of Parkinson plus syndromes.
Right.
So there is something called PSP, progressive supranuclear palsy. Again, in PSP there are some 2-3 clinical phenotypes.
Okay.
One can present with the typical Scheidegger syndrome, where you have recurrent falls. There is a dysarthria, dysphagia,
Right.
supranuclear gaze palsy. So this is the typical PSP-like phenotype. There's also another phenotype which just looks like exactly like Parkinson disease,
Okay.
but symmetrical disease,
Okay.
poor postural control, some level of responsiveness and all.
Okay.
And there is also other type where they have predominantly gait freezing.
Okay.
So this is one PSP thing. Whereas there is also something called multisystem atrophy.
Okay.
So again, in multisystem atrophy, there are 2-3 clinical phenotypes where you can have predominantly autonomic dysfunction, a lot of autonomic dysfunction in the form of urinary incontinence, have orthostatic giddiness, blood pressure dropping, have syncopal attacks. Or there is, as I mentioned, about cerebellar type. And there is a Parkinson type. So Parkinson type of my MSA looks very similar to the idiopathic Parkinson disease.
Okay.
But there are subtle differences where the disease is symmetrical, more rapidly progressive.
Okay.
The non-motor symptoms are much more faster, and the response to levodopa is muted. Within 1 year, 2 years, they don't respond. However, higher doses, and they don't tolerate the medications also. They can have orthostatic drop in blood pressure. So all that can happen. Okay. So these are the things. So as I mentioned, when we follow them up, whether it is a typical Parkinson disease or atypical Parkinson disease, we follow them up regularly.
Right.
So when we see these atypical features, setting in, because we need to examine them in detail, apart from the history taking, we examine them, we look at, early falls, then our, antenna goes up. So we don't expect that to happen in idiopathic Parkinson's. So as a movement disorder specialist in Parkinson disease, if something happens very, unusual, in course of the disease, then our antenna goes up, and then I think then we take help of, investigations like MRI brain, or sometimes we use, but unfortunately the functional nuclear scan doesn't help differentiate. So we again,
structures.
Those structures, the uptake is the same. So it may not, only thing asymmetry versus symmetry may be a little bit helpful, but otherwise it's mostly depending on the clinical thing and the progression of the disease. So the decision is very important. I mean, the differentiating Parkinson and Parkinson plus becomes very important, because we know for sure that Parkinson plus syndromes don't respond to advanced therapies. They're not the candidates for deep brain stimulation.
Right.
So we will have to manage them with medications and supportive care.
Right.
So the progression is faster. The caregiver's help is much more required. They require much more assistance than Parkinson disease. 24/7 caretaker is required, because they have poor balance. They may fall. There are high risk of fractures. So in these patients, they will develop swallowing difficulties. So someone is there to guide them to swallow, feed. So small requirements becomes challenging, and they require assistance.